Hello, and thank you for joining us for the fourth installment of Fusion5's BPCI Advanced webinar series. This webinar is focused on the post-acute care network development and alignment and management. My name is Jason McCormick, and I'm the Senior Director of Value-Based Care for Fusion5. I'm joined by another member of the team, Sean Matheson, and I'll let Sean introduce himself now.
Good afternoon, everybody. I'm grateful to be joining you here with this time. I have some background, I should say about 20 years of background in post-acute care. Most recently, I was developing post-acute networks in 4 states for the largest hospital and hospitalist convener in the country. So I look forward to sharing some strategies and best practices.
All right, thank you, Sean. And my background, folks, is working in one of the physician group practices and running the BPCI Classic program for that physician practice. So let's take a look and talk about our agenda today. So we're going to begin with just a brief overview of BPCI Advanced. Most of you have probably already heard these overviews, so we won't spend a lot of time on that. We'll move quickly into the CMS post-acute care requirements and what is required of us for working with the post-acute care facilities and those providers. We'll talk about the network selection and basically finding the right partner, the right service provider for you and for your patients as you go into the BPCI Advanced program. We'll talk about some PAC program strategies, basically some ideas for working with the post-acute care program and for how we can make that see the best opportunities for your practice and your patients. And then we'll end it with a little bit of talk about some of the community resources that may be available for patients that you see that may not have other opportunities. If you have any questions during this presentation or after the presentation, feel free to email info at fusion5.us. You can leave any questions you have there and someone will reach back out to you as soon as possible. So let's get started on what is BPCI Advanced. So BPCI Advanced is the next generation of the original BPCI program that was released back in about 2011. It's a further progression of the value-based healthcare movement. The program is based on clinical episodes of care that come from DRGs. So there's 29 DRG-based inpatient clinical episodes and 3 outpatient clinical episodes that are included in BPCI Advanced. So what determines an episode? So as you kind of see above, you have an anchor hospitalization. So that's the hospital admit and the surgery that happens. Now, once you have that inpatient stay, then the patient moves into the post-acute stay. So any of those things that happen during the 90 days once the patient has been discharged from the acute setting will go into this episode. When we're talking about the anchor hospitalization, one of the things that we're going to want to make sure of is that the attending or the operating physician's NPI is listed on the UBO4 form, and that's linked back to the correct 10. If that's not taken care of, then those patients will not be attributed correctly to the BPCI Advanced program. And again, the duration of the bundle or the episode is that acute care service or that surgery and that inpatient stay, and then all of the post-acute services that the patient receives 90 days post-discharge.
So speaking of those post-acute services, that naturally is the majority of time during the episode. Therefore, a great deal of focus needs to be there. It's very interesting to look at the history of the costs for those bright 3 circles there. Costs that Medicare has outlaid, or spending I should say, has more than doubled from 2001 to 2013. So Medicare was outlaying $27 billion to post-acute in 2001, over $59 billion in 2013. So you quickly get a picture for why this might be of focus and a program that Medicare wants to go forward with. One other quick note here on costs. There was a Medicare Payment Advisory Commission brief in 2013. They looked at not only the costs of post-acute, but the variation. So significant variation, 16 to 32K episode cost variation for lower extremity joints. And most of that variation comes with the post-acute. Do you send your patient to IRF, to LTAC, to SNF, to home, to outpatient? These are the type of strategies we'll get into here, but just want to set that big picture that this is big cost and wide variation from the perspective of Medicare.
Yeah, thank you, Sean. And that kind of brings us into the way that your performance is going to be judged in BPCI Advanced, and then kind of how the Fusion5 partnership is going to help really with that care redesign. So as you can see here, your performance is really based on all of the things that happen 3 days prior to the surgery and then 90 days post. So, the discharge destination, readmissions to the hospital for any type of cause almost, and then your inpatient rehab, your skilled nursing facility, your home health, and then outpatient therapy. All of those different things come together with the rates and the length of stay to really look at that overall performance and the overall dollars with the spend. So partnering with Fusion5, we're going to help you to redesign the care that's currently delivered to those patients. So we're going to do those things by looking at readmission rates and hoping to decrease those if they're a higher rate, looking at comorbid conditions, and does the patient have some things that we need to address prior to their surgery, hoping to, take down the number of ED visits or post visits for things that may cause a readmission to the hospital. Maybe patients are going in because they see, some redness and swelling that is to be expected, but then when they get to the ED, somebody ends up admitting them. So that goes back to, again, your performance as a provider, or your performance as a practice. We'll look at discharge planning, what's going on with the patient, where we want them to go, and into that preferred provider network. Really optimizing the care of your patients. Is there something that we can do for these patients prior to them getting into surgery? If that's, smoking cessation programs, or, helping them lower their BMI prior to surgery. Those are the things we can help with. Setting up your preferred PAC provider network so that you have facilities that work with you and within your physician's guidelines. We do a lot of these things, and we help to figure these things out through risk assessments. They're constantly going on to make sure that we're maximizing the potential opportunity for the patient. And then coordinating care, whether that's inpatient care or post-op care. We want to make sure that we're aware of everything that's going on and helping the patient control all of those those visits and those costs associated. So we're also going to help with patients that have behavioral health needs, or if there's any social determinants on the way that the care is delivered, or the type of care that's delivered to those patients.
There's a real fluidity here when you think about care redesign. It's a flow from pre-operative screening and planning through the whole perioperative process, and it's really interesting to me how it can vary so much market to market. Certainly, there are gold standard denominator things that work in every market, and then there are the specifics to your practice. What works best in your area? And I think a couple of things for you to consider as you're looking at conveners are which convener has the most robust clinical team and the most robust administrative team, in your opinion. I've seen a number of conveners that have good data science. I think that's fairly true of most. But really, when the rubber on the road is there, the art, if you will, not just the science of bundle convening, it's really important to look at who has a really robust clinical team and a really robust post-acute management team. For example, I'm on the administrative side of the post-acute management team in a regional role, and I have 20 years in the post-acute arena. So these are the type of resources and strategies that we hope to bring to you.
Right. So looking at, the cost to manage the care prior to BPCI advanced or prior to your participation, some of the things that you may notice when looking at the overall cost, obviously the inpatient surgery, episode is going to run somewhere roughly in between the $11,000 and $13,000 range. So any of the post-acute services that add on to that really push your numbers up. And so historically, when you're talking about inpatient rehab, you may be looking at an additional $15,000 to $22,000 per episode. Someone in the skilled nursing facility, that possibly is an $8,000 to $12,000 stay. Home health services typically we're running $2,000 to $4,000. Physical therapy services can be somewhere in between $1,000 and $2,000, and then in the worst case scenario, readmissions are somewhere in between $12,000 to $18,000. And so when you stack those costs on top of the acute care cost, you really begin to get a picture of, how expensive some of these post-acute care types of facilities can be to this patient population.
It's interesting to look at everyone's data, specifically everybody's PGP data. We have 2016 and prior data. We've provided those opportunity analyses to you. And if you haven't had that yet, please contact us. We'd be happy to get that to you. When you look in aggregate and when you look at individual PGPs in respective markets, it's so interesting to look at the micro of this and then look at it on the macro. On the macro, we're talking about the doubling of PAC costs since 2001, the wide variation from 16 to 32K in lower extremity joints. It's not hard to see on the micro when you start to look at some of these numbers and specific to your practice, how these stack up. I call them bundle busters, some of the higher cost IRFs, SNFs, every opportunity that is clinically practicable to get that patient home with that physical therapy service really helps provide a more efficient care and better value.
Well, thank you, Sean. Let's move into what actually are the CMS requirements for post-acute care and the things that we have to make sure that we do when dealing with the CMS beneficiaries or the Medicare beneficiaries. So the first and really the most important thing to remember is that the beneficiary's choice of service provider, they have the ability to make any decision on where they would like to go. If we realize that a patient needs to go into a skilled nursing environment, the patient really has the option of choosing where they would like to go. Now, that being said, what we at Fusion5 will be doing with your team is working to identify those real preferred providers, those partners in care, so that when you are offering, different environments of care, different facilities to a patient, you can tell them, these are our partners of care. These are the people that are willing to work within our physicians' kind of program guidelines, and those that are, going to adhere to what the doctor would like for you to do going forward. And so even though, the patients do have the choice of choosing that service provider, but we really want to point them into the place that's going to work within those physician guidelines or suggestions. So the skilled nursing facility star rating. So this is an important thing for everybody to remember because CMS publishes skilled nursing star ratings. So it's a rating system that measures them against each other, and so we obviously want to use the higher star facilities, because that's where the better care and the better quality service is going to be delivered. The skilled nursing facility waiver. So this is a waiver. CMS offers several types of waivers for this program, and the skilled nursing facility waiver is one of those. This waiver is for you or to use with those patients that need to go, once discharged from the acute setting, they need to go into a skilled nursing facility, but we don't have to have them wait the typical standard, third night before they can be discharged. So if you have a patient that is, a BPCI advanced patient, you can utilize the skilled nursing waiver to get them in, the day after surgery or wherever they need to go as quickly as possible to get them into the right level of care. And then again, there's other types of beneficiary incentive waivers that are approved by CMS. They're not covered under the Medicare A and B benefits. We do have to report these to CMS, and eventually they may be audited. So we want to keep up with these as well. And there's a lot of different waivers that we can use with our patients. During my time at Campbell Clinic, we've used a lot of the different waivers. The one that I personally would love to use is the waiver that allows you to actually board a pet so that, if that pet is potentially a stumbling block or a barrier to getting your patient discharged home, CMS has given us a waiver to allow the physician group practice to board that pet for, a certain amount of time and a certain cost, so that the patient will not have that stumbling block to going home or to going into the correct facility or the, for the correct level of care. So it's just an example of the types of waivers and the way that CMS has really structured this program so that we can do right by the patient, not overutilize care services that are not needed, and really get patients home to where they can recover in their own environment to the best of their ability.
I'll add color just on the first 2 points there. On patient choice, it's a tremendous amount of trust that patients put in surgeons. What an invasive thing, a surgeon to open me up and implant a device. I certainly am going to trust that surgeon with his or her advice of my care pathway and what he or she thinks is best for my care plan. And then on the skilled nursing facility waiver facility star rating, it's very interesting to look at the methodology there, because the top star, the 5, can only be distributed among the curve for the top 10th percentile of SNFs. So we tend to think of 5 stars in terms of Yelp or Google or different things that we can review and have an unlimited amount of 5s. But with the skilled nursing program, and it's the same with home health compare, that top 5 is reserved for the top 10 percentile. So with that is the suggestion that there are some very good 3 and 4 star facilities that we can work with. Some up and comers, not everybody can be in the top 10th percentile with a mandatory curve, the way CMS has put that out there. So a lot of detail goes into the selection of the network, and certainly the patient is always at the core of that choice.
Yeah, and that goes directly into where we're going to move towards, and that's really the network selection, or finding the right partners to deliver these services to your patients. So let's take a look at an example of a post-acute care data analysis report that Fusion5 will present to you and to your team so that you can begin to really look at the information. So you'll see at the top part, this is the top 10 episode DRG KPIs, or key performance indicators. And you'll see the DRG 470. So that DRG is obviously the total lower extremity replacement. And so that's usually going to be the #1 episode that any of these groups are going to have. So you've got a 689 number looking at this with an average cost of $17,000. So as we go across, and what our data analytics tool is going to allow you to do is look at your utilization. So that's, as you go across, you see a utilization rate of inpatient rehab for DRG 470 of 1.5%, a skilled nursing utilization of 17.7, home health of 14.1, and then outpatient percentage of 48.1. So basically that is the number, or really the percentage of the number, the total amount of patients that went into those post-acute care settings. You'll also see that a readmit percentage there, 7.9%. So that's saying that out of those 689 patients, approximately 7.9% were readmitted into the hospital. And you'll notice we have the kind of the stoplight type of system there, the red and the yellow and the green, basically saying that these are areas that we may want to pay attention to. Now, this type of report is going to be customizable by practice. So if you need your setting to be a little bit lower than what we have, you're able to customize that. And again, looking through this type of report is going to tell you where you may have some opportunities. So looking at, potentially the, if we're looking at the DRG 470, we're probably going to spend some time looking at our readmission rate and seeing what's going on there. And looking at maybe a 469 where we had 19 patients, maybe we're going to spend some time looking at everything across the board, readmission utilization, IRF utilization, and skilled nursing utilization. All of these things are opportunities, or potentially are opportunities, to drive down overall cost and put those savings back. You'll notice at the bottom is basically breaking those post-acute KPIs down by the clinical episode. So for major joint replacement of lower extremity, that includes both DRGs 469 and 470. So the difference in between a regular major joint replacement of lower extremity and one with major complications. So not only does it break it down again by utilization, it's going to break it down by the total dollar spend that went into those facilities. So now you can get an idea of, let's take a look at, say, DRG 470. When we look across and see that, our skilled nursing facility, the utilization was 16.4, which is a very, in the green area, that's a pretty good utilization of skilled nursing. Now, if you look above for DRG 469, you'll see a 57.9, which, fell into the high range. And so that may be an opportunity. What we also see, and what I think is much more important, and the devil is in the details, is looking at the length of stay of those facilities. If you'll notice, when you look in the length of stay for all the DRGs, every one of those is in the red. So, this is definitely something that we would want to focus on for your preferred providers, and to see, why somebody is staying for that total length of stay. So again, for a 470, does a patient really need to be in a skilled nursing facility for 20 days? With my experience at Campbell Clinic, we really kind of tried to set the bar in the top, 10%, and we were trying to keep our average length of stay somewhere in between the 7 to 12 day, more to the 7 to 9 day post discharge from the acute setting. Now, that doesn't mean that your preferred providers or your provider partners are going to be required to work within those days, but that's just sort of a baseline to where you expect those preferred providers to work with your case management staff, especially if something's going to be going above that length of stay or that expectation. We want to make sure that there's a clinical reason for why they're going to be there that long. Again, you see that, for 16.4% of the patients for DRG 479, with a length of stay of 20 days, that was a total spend of $1,047,000. So, reducing that length of stay, cutting that length of stay in half potentially saves, $500,000 right off the bat. That's before you look at your preferred providers or anything else, just with dealing in the length of stay. So there's a lot of opportunity there, and this type of report is going to show you some of those things.
This is an interesting clinic to me because you've got a really low cost market. Looking at their 470s, that top left, that have an average cost of $17,115. This is definitely a top 10th percentile, i.e. lowest cost market. And yet, being such a low expense market, as Jason was saying, you've got about $1 million in SNF spend across those 470s, coming down to that bottom section there to the right. And then in IRF, you've got about 200 in spend. So just right there, 1.2 million is being outlaid in SNF and IRF, and this is a very low cost market. So we will help you have those conversations with the nursing homes, the skilled nursing facilities. People like me that have the skilled nursing experience background can say exactly what Jason just said. Hey, your length of stay is at 20. Our guideline is 7 to 9. There's kind of a Hawthorne effect. When people know that something is being measured, it tends to produce change in the result itself. If a nursing facility has a traditional Medicare versus a managed Medicare patient, i.e. Medicare Advantage, length of stays do differ in practice. SNFs will tell you that they don't, but it does. We simply ask that the patients be managed in a managed care way, so that the care plan of therapy be one similar to Medicare Advantage, where they optimize the patient for the next site of care rather than have a long length of stay. So it's just a shift of paradigm and a structured approach, and it can really produce changes very quickly.
Right. And as you really dig down into the data that's provided by Fusion5, you're going to see how those opportunities may stack up or where those opportunities may be. So at this level, not only are we looking at the aggregate skilled nursing utilization and the dollars, as we move into the next report, this is really as a person who was handling the BPCI Classic program at Campbell Clinic, this is one of the places that I'd like to spend a lot of my time. Now, if you take a look at this report, what this does is it lists out all the different post-acute providers that this clinic, used over the course of this 2016 period. Now, again, these are blinded, says post-acute provider 40, but your report would have the actual facility names there. And then you see that the facility type, so it's a skilled nursing and then inpatient rehab, skilled nursing, all the way down to outpatient therapy part there. And then you see the patient count that went to those facilities during the included time. Again, you see the total claims, the average episode cost, the average case cost, and then the direct readmit utilization, or the direct readmit percentage, and the average comorbid that those patients had that went to those facilities. So as somebody that's working in this program and trying to identify who that preferred network should be, I'm going to spend some time here looking at these issues across the board. So according to this report, it looks like there's 4 different skilled nursing facilities that we're sending patients to. Now, if you look, you've got one that has 34 patients with an average cost of $9,000. You look down and you see that the next one, a number that was 13 patients, and you have a $15,000 average cost. Now, why is there such a difference in between the two? That's something that we're going to want to look at and see if there's issues going on with the one, post-acute provider 18, something that they were doing or a reason that they were, much higher than the previous one. And again, you do the same thing with the inpatient rehab facility. We're looking at a total of 27 patients that went into inpatient rehab facilities for roughly an average episode cost of about $52,000. Well, that is an extremely high amount per episode. So we want to look at, did we have these patients going into the right level of care? Should they have gone to an inpatient rehab facility, or should they have gone into a skilled nursing facility, or even should they have been discharged home with outpatient therapy? Again, looking at the readmit rate or the readmit percentage, you're going to see that that second inpatient rehab had a 15.4% direct readmit. So even if we're going to be sending patients to these rehab facilities, we're going to look at why there was such a high direct readmit rate for those patients, compared to the inpatient rehab facility before it, which had none. So, really spending the time and looking at these types of reports in detail is where you find a lot of your opportunities. A lot of your low-hanging fruit will be found here in this type of report. And you'll notice at the bottom, what we have there is the benchmark comparisons of your group compared to the 90th percentile, or the top 10% performing based on the OrthoForum or OrthoConnect percentages. So this group, for example, for readmit percentage is at 7.2%, when the top 10% was at 2.9. So obviously we've got some work to do to be in that top 10%. And the same is true with the skilled nursing utilization. Your group, or this example group, has a 17.7% utilization, where the top 10% has a 12.8. So that's just kind of a quick visual to show where you are compared to the top 10% of performing groups.
This particular physician group practice is a good example in these numbers of, I think, an IRF bundle busting factor and a SNF variation, both of which we've talked about at a high level, and this now gives kind of that specific micro level. On IRF, for example, notice that they're each contributing the IRF about 17,000 to the overall episode, and the overall episode then turns to about 50K. If your target calculation, say, was 25K, that's a loss of 25K per episode. Very significant money very quickly. IRFs can be bundle busters. And then on the skilled nursing side, this is an example of variation. You see that SNF 40 spends only 9K, SNF 18 spends 15K. Well, you might expect if you were to go to that nursing home, they would say, we have sicker patients. But in fact, SNF 40 had the lower cost at 9K. Their comorbids were 2.5, and SNF 18 had at the higher cost, had much less comorbidity at 1.7. So these are the type of things that data can show us. And the good news here is if we have a SNF who maybe doesn't have as good of data, but they have the right leadership, our experience is SNFs will change pretty quickly. And again, the caveat there, the conditional statement was if they have good leadership. They want to play ball. This is a market they understand that is changing with ACOs, with bundled payments, and they want to have that 9-day length of stay. Orthopedics is a cut and dry, if you will, type of episode for a SNF. A lot of folks are very ambulatory. There's not a lot of high-cost meds or other things for the nursing home. So we have some leverage there to work with those providers that are higher cost if we need to. In our experiences, most of them will be reasonable and change, but certainly when we see the data of who is better performing, this is just very revealing for IRF bundle busting and SNF variation and who we can best work with.
Right. And, I definitely think that one of the great things about the information as it's presented to you and what Fusion5 is hoping to do with your practice is really help you identify who those groups are that you want to partner with. So, the group that was a perfect example that Sean just shared of the two skilled nursing facilities looking at their average comorbidity and their cost. So we really want to get in there and find out who is the right group. And the leadership, that Sean mentioned, that plays an important part. Not only is the leadership important there, but working with that leadership to, kind of give them the suggestions. And here's the things that our providers are going to require of those groups that we partner with. So then getting that leadership to back that and to understand that and agree with that and be willing to make sure that they follow those requirements. That type of information is powerful, and that type of way of working is powerful, and that's what's going to achieve the best results. So looking at some of the other reports, and this, again, is a lot of the same information cut different ways and presented different ways so that we can help you to make the right choice when it comes to your provider network. So what we're looking at is inpatient rehab facilities for the 2013-2016 baseline period. So here you see a selection of 4 different inpatient rehab facilities with varying numbers of episodes, and you just look at it a different cut way. So you can see a huge swing in the average episode spend. You can see some swing in the average length of stay. And again, with the direct readmit rate. Now, one of the things that's interesting in this type of report is you're going to have the CMS ratings as well. So that can help guide you on the path of which facility you want to partner with or which facility you may be able to partner with. This is just a snapshot, and I'm going to go ahead and advance. Like I said, we're going to see several of these different same type of reports. So this is your inpatient rehab facility report. You have a skilled nursing facility report, which is going to do the same thing. And as you see, it lists out the different facilities that were utilized during that baseline period and the numbers that kind of go with that. So the total volume, the average spend, the average episode spend, cost per day, length of stay, readmit rate, and then the star rating. So, looking at this report, it's kind of interesting if you look at average length of stay that you see that skilled nursing facility number 2 was much less than all of the other locations or all of the other facilities. So is there a reason, that we're using those higher length of stay facilities comparatively? You've got a much higher cost per day in the other 3 compared to skilled nursing facility number 2. So what is number 2 doing that is right? They're doing something that is keeping the patients for a less amount of time. You have a readmit rate that is less than all of the others and a good star rating as well. So we're really looking to probably partner with a facility number 2 so that we can, help drive down those costs. Even looking at average episode spend, you see a huge difference in between. So that is the type of report that we're going to use to look at to see that skilled nursing facility 2 would probably be one of the groups that we'd want to partner with.
Looking at skilled nursing facility 2, if I would bet walking into that facility, that is probably a group that has very good leadership who has embraced value-based care. I would also estimate that they have a very high Medicare Advantage population, different contracts that they have for that. Some of these higher length of stay facilities, they may actually be really nice, newer stick and brick type facilities, but because they've been able to receive the majority of the traditional draw in the area, they don't necessarily have that compelling reason to want to engage a lower length of stay, since their rates are based on a daily factor. So a number of different things could be at play here. Certainly the ability to go into the facility, get a finger on the pulse, know what the market is in terms of Medicare Advantage, what the proportionate Medicare traditional draw is by facility. These are all the type of details that we can help ferret out and to get a proper assessment of.
Right. And going forward, we have the same type of report that's going to be available for your home health care as well, looking at all the different home health facilities that are utilized. But again, all of this information is available to you and is something that you'll be able to use to help pick out your preferred provider network. So let's kind of move into the post-acute care program strategies, or the things that we're going to really want to help kind of do with your preferred providers that your practice decides to partner with. So building that PAC preferred partner list so that we can help reduce length of stay and readmissions. These are the things that we just saw in those reports and that Sean and I were both kind of talking to. We're going to help you pick out those partners and then have those meetings with them so that we can identify, here's the things that we're looking for in a partner, and are you able to do these things? If you are able to do these things, great. If you're not, then, thank you, but we want to use a different partner that's kind of willing to work with us. Discharging patients as appropriate to home with home health care and outpatient services. Not every patient who has an inpatient total joint needs to be going to a skilled nursing facility or into an inpatient rehab facility. There's an appropriate number that, really need to be going home, and maybe with just some home health or some outpatient PT, those patients will do as well, if not better, in a clinical outcome than those that are going to another facility. It's putting the patient at the right level of care. Helping you with protocol and process development for all of those different post-acute providers. Fusion5 is going to be there. We've got the clinical staff as well as the administrative staff, as well as proven protocols and processes, things that we've used at Campbell Clinic, things that have been used at a lot of other providers across the country that have proven to work. Those are the types of processes and protocols that Fusion5 is going to bring to your group in order for you to implement those. Another one, another thing, strategy is how do you take care of trauma care? If you provide, call coverage for traumas, what can we do to identify those patients better? A lot of times when you are getting information about a trauma case that came in, you're usually following them or figuring out about them once that patient's already been discharged to an inpatient rehab facility. So maybe we can help, setting up the protocol that'll help you identify them sooner rather than later so that you can help with the process of getting that patient, to the right level of care instead of finding out once you've already signed on for, an exorbitant amount of money for something that patient may not have needed. Getting our clinical staff involved with your practice and with your physicians to figure out, the clinical evaluation and treat on-site type of rules or, protocols that post-acute services can have, instead of just transferring those patients to the ER for things like, urinary tract infection or hypertension or to rule out DVT. At Campbell Clinic, one of the things that we set up was having the post-acute providers, if a patient was needing, some type of medical services, we wanted that post-acute provider to reach out to our case manager, to our physicians to discuss that prior to any type of transfer or any type of care really being delivered. Now, of course, if it's an emergent issue, you want that patient to go to where they need to go. But if it's something like one of these issues, or just again the redness and the swelling, those are things that can be treated on site at the post-acute care instead of going into the ED and then maybe becoming a readmission. Fusion5 is going to help with your post-acute care training and education for your facilities. We're happy to come in and talk with them and help set up those requirements or those protocols and help them develop the things that they need so that they're successful with your patients. And then again, all of these things, all of this information and all the, how the providers are doing comes back to you through the data analytics. And so you can measure their performance and you can measure the outcomes and see that if there's a facility that's not doing exactly as well as we had hoped or as well as they, were planning on doing, then you can identify that ahead of time, before you get too far down the road with working with them in the future.
Speaking of the clinical piece, we have what I call a dyad model, where you have a regional clinical director, and then also a regional administrative director, myself, Jason, being on the latter. So every good operation that you've likely seen in your career has that balance between clinical and admin. And that's exactly what we strive to have with Fusion5. So seeing these clinical conditions and having these type of conversations, clinician to clinician, expert to expert, it goes so far. And as well, it does when an administrator speaks with an administrator. And when I am able to have those conversations with data on that last point Jason made, it really creates that Hawthorne effect that I mentioned earlier, but it also creates a competitive effect. Nursing facilities, home healths, they're very competitive, just like orthopedic groups. And when they see unblinded data of how they're performing against others in the network and out of the performance network, it's good. It creates a lot of good competition. And we harness that into a feeling of camaraderie, where we gather our post-acute preferred network together. We can have quarterly meetings with our network. I call those town hall meetings. Just a lot of different strategies that we can deploy to capitalize on the resources of Fusion5 and the self-interests and the expertise of the network.
Right, and you know, that goes a little bit deeper, and even having not just people like Sean or myself that can come in and do that, we also have a lot of you know, specialized individuals that can really deal with different types of issues on the patient population. So, you know, speaking of that, about addressing the social determinants of health. So all the things you know, that you're going to be identifying about these patients ahead of time. You know, Fusion5 has social workers and, you know, other providers of care or other people that are going to be able to help you identify any of these special needs that your patients may have. You know, you're identifying certain situations about your patients, you know, maybe even month or 2 months prior to surgery in the majority of elective cases. So you're going to figure out the social determinants, such as, you know, social isolation. Is the patient alone? You know, if there's a gap in healthcare services or some sort of gap in the access to care, if there's language or education barriers, you know, the difference in between an urban population and a rural population, you know, there may be services that are different for one or the other. And then again, financial limitations. Does a patient not have access to medication or to healthy meals that are going to help them with their recovery? So we have the staff that can help with identifying a lot of these types of special needs, and then set you up with, or set them up with, you know, elder care services or community support groups, things for maybe, you know, depression type of issues with community support groups. It kind of moves you into behavioral health, talking about the needs of any patient that may have some sort of behavioral health issue. You know, for example, depression. It's clinically proven that patients with depression, you know, potentially have a higher average cost or a higher, you know, poor outcome percentage than patients without. So helping to identify that ahead of time and knowing what services you can put in place for those patients really can be in the best interest of not only you and your practice, but also in the patients themselves. And then knowing about the social services that are available to them.
This for me is just what makes you feel good about creating value in your market at your clinic. You know, the financial motivation before was to address these as much as we practically could prior to operation. But now that there's a 90-day episode of total cost of care and total quality, there's an interest in creating and addressing these determinants. There was a study in published in Health Affairs by McGinnis. You would not be surprised. You know, intuitively, we all know 2/3 of the reason high need individuals readmit to the hospital are behavioral, social, and environmental. One of those 3 factors. So to the extent that we can bring these people preoperative help, identify this through risk assessment, we have the network of information regarding your community support groups. We'll be building that collaboratively with you. Plugging these people into those programs is really, for my heart, I think that's where the art of episodes and creating value for patients is.
Yeah, and I completely agree with that, and it's a perfect segue into the next area, which is really dealing with the community partnerships that we can help you create or take advantage of by being your convener of choice. We're able to utilize those waivers that we referred to earlier to do things that you've never been allowed to do before. So, helping to provide low-cost services in lieu of those high-cost long-term facility stays. So, historically, a patient may have gone into a inpatient rehab or a skilled nursing simply because, they didn't have anybody at home during the hours that they were awake and up and at them, so that, they would just put somebody into a facility. Well, utilizing waivers, what we can do is work with community partners such as home aid type groups to provide a service to that patient where for the hours that maybe the patient is awake, you have somebody that's in the home providing care and is there to help. And that reduces the need for that inpatient type of inpatient rehab or skilled nursing type of stay with huge amount of dollar difference in between the two, and the patient still receives the care that they need at the appropriate level of care, home. So again, there's all these different types of preferred provider waivers that we can implement and help you take advantage of. Things for transportation or short-term home health care aids, assisted living and DME, virtual therapy programs. I mean, even the one that I used earlier in the case of boarding animals. All these waivers have been provided by CMS for us to take advantage of. And so we really, we want to get in with your practice and help identify how you can use those waivers and who are the groups and the partners that you want to utilize. And the same thing goes true with community resources. There's a lot of resources that are available that our social workers, can help with, so that if patient has an issue with, the healthy meals types of thing, we can get them set up with Meals on Wheels, or if they need certain services, setting them up with the area agency on aging or the Alzheimer's Association, any of those services that we really can deliver to those patients to help with the outcome and reduce the overall spend.
On those waivers, Jason, I'll speak for you here with Campbell Clinic. I know you had set up those private duty caregiver waivers, as you had mentioned, and how significant that was. I've had experience working with a different convener, setting up the assisted living waivers, and it's just amazing how well patients do when they're in an assisted living versus a skilled nursing environment. It's almost seen to the patient as a respite, in a place to kind of get tuned up, if you will, before going home. I love these waivers that Medicare has provided. And there's so many creative things that we could do. I would just add one to this list of community resources at the bottom, and that is home visit medical groups. I helped form what has become Utah's largest home visit medical group. I no longer have an interest there, but that's something near and dear to my heart, that you can actually bring a nurse practitioner, a PA to the home. Actually, another bullet point here would be telemedicine. The CPT on that goes live as allowable outside of rural. Currently, it's just rural that is paid on 1/1/2020. These are the type of things that we can deploy now or in anticipation of certain allowable dates. But this is a long list here that things we would not otherwise be able to provide. But through the waiver program, we can get patients to the right type of care that they need and really tailor that care plan innovatively.
Yeah, thank you, Sean. And to expand on what you said about Campbell Clinic a moment ago, I do have to brag and was speaking with our case manager at Campbell Clinic earlier today. And one of the things that we learned recently through our data that we keep up with for BPCI Classic patients is that we just really moved the needle in the skilled nursing facility utilization even more than we have done previously moving it roughly from around 14 or 15% utilization down to a 7% utilization. And really the reason that we were able to do that, or the reason that that has been done, is because of the partnership that we created with a short-term home health care aid company. So we were able to decrease that utilization another, 10% or so roughly, just by partnering with them and getting them involved in some of those cases. So, even once we have really moved the needle a good bit from where we started back in 2014, we are still continuing to do that by looking at other ways and looking at how we can do things with other preferred providers. So that kind of moves us into just the talk about next steps and what's coming up. So we do currently have an upcoming webinar that's going to be based on care redesign. That webinar is going to be scheduled. It's May 30th at this moment. You should have received an email about that. And if you haven't, please reach out to us. Reach out to us with any questions. You can email anything to info@fusion5.us. We are here to help you. We want to see all of our group practices or any of the groups that are participating with us. We want to see you do as well as we can. And so any questions that you can ask, we're happy to answer them. Scheduling face-to-face meetings. We are out currently going through opportunity analysis reviews and having administrative meetings, physician meetings, really talking about the paradigm shift that is the transition from fee-for-service type care to value-based care, and how we are helping partner with groups such as all of your orthopedic clinics to really move the needle and getting care more towards value-based, and how we can bring that to your practice. Also in the future, please go ahead. Hopefully you've received an email about our BPCI Advanced Conference that Fusion5 will be putting on June 27th to 29th in Dallas. Again, if you've not received information on that, please reach out to info@fusion5.us, and we'll be happy to make sure to get something to you. So wanted to just thank everybody again. Remember to please reach out to us if you have any needs or any questions. We'll be happy to do that and happy to answer your questions. I want to thank Sean for being involved and for helping me out with this presentation, and we look forward to hearing from you in the future.
Thank you.